Patients are waiting several hours to be seen in the emergency department.
50% of those transfusions are inappropriate. Is it also causing harm?
Marianne and Christine sit down with Dr. Ivo Beverina, a leading transfusionist, to uncover just what is lacking.
The leading cause of death accounted roughly 30-40% of fatal reactions from transfusion.
Your blood, your health, it's in your hands. Speak up loud, take your stand. A voice can shift the tides of care. Your blood, your health, be aware.
Thank you as always for tuning in. And today our special guest is Dr. Ivo Beverina. Ivo, you're from Italy.
Yes, from Italy, from northern Italy.
The northern Italy. That's fantastic. Since is this correct? Since about 2015, Italy has had patient blood management mandate for medical organizations. That's very exciting. Can you tell us how this came about and how it's going now?
You started with fireworks. How it came about, I don't know, since I never spent time in the hall of power. In my opinion, it was a strange decision under several points of view. And how it's going, it's a bit embarrassing to us. Since national reports show that red blood cell consumption has not declined since the mandate was introduced into law. Actually, the national charts from 2015 to today show a flat trend, and red blood cell consumption has remained between 40 and 42 units per 1,000 inhabitants. Things are a bit better for plasma, with around 37% reduction in national consumption in 2024 compared with 2018. However, the impression is that this decrease is more physiological than the result of an structured patient blood management policy. I suppose you are wondering what the reason to the failure are. In my view, is caused by a number of reasons. The first is that no resources have been allocated to the implementation of PBM, neither financial nor human. And we know well how the implementation phase requires resources, both in terms of funding and dedicated staff. The result and savings will surely come sooner or later. And again, these resources must also be used to create data collection platforms. One click, and you should know exactly how your PBM program is performing. In real life, we spend hours and hours in front of a computer just to get the data. That's exactly what I've done for my publications as well. Another reason is that the hospital administration rarely know the subject. This is an important point, and even more rarely support its implementation. They often think that PBM is something only for transfusion specialists, and not that its implementation involves the whole organization. They are not clear about who the stakeholders are. I've been in my new position for 9 months, more or less, and just a few weeks ago, I gave a presentation of PBM to the strategic management of my hospital, because the implementation must be structural within the organization and not left to the goodwill of the individual transfusion specialist, the individual anesthesiologist, or the individual surgeon. In my opinion, effective results are achieved only if the 3 pillars are implemented simultaneously in a synchronized way. I can correct pre-op anemia, but if restricted tissues are used neither in the operating room nor in the ward, all the work done before this was. Going back to the answer, last but not least, there is the lack of passion of transfusionist profession in Italy. Don't ask me why. I was born as a transfusionist, and I will end my professional life as a transfusionist. I enjoy what I do. I struggle to understand why this job no longer excites young people. To tell the truth, the real reason is probably that there is no specialty in transfusion medicine in Italy. So many colleagues don't even realize how clinically relevant our work is, and therefore they don't see it a real career opportunity. As a result, we simply can afford to dedicate one medical unit to reviewing the appropriateness of every single transfusion request, since our staff is just enough to survive. Sorry for venting, man. Something sometimes all is frustrating. If I may, before you go on with your question, let me change the subject for a second because it's something I really want to say. And I want to emphasize the importance of the nurse's role in PBM. Nurses have a closer and more direct relationship with patients. They are often the first to perceive their immediate needs, both physical and emotional, and they are the ones most present at the patient side. In short, we couldn't do without them. Sherry Ozawa, we know her very well, one of the past president of SABEM. By the way, in my country, the idea of a nurse becoming a president of scientific society would be unthinkable. You are, let's say, a bit more advanced in this respect. Sherry Ozawa and certain Marian Stromowski, I don't know, you know her, published a wonderful article right on this topic. Very wonderful
Thank you.
article. As a man, I have to say, also, regardless of their profession, there are many amazing women working in PBM, besides you two, Elvira Bisbe in Spain, Diana Castro Pauperio in Portugal, Rosa Spinoza in Norway, Caroline Inas in Wales, Caroline Vaz, past president of SABM in USA, in Italy, Vanessa Agostini, Maria Beatrice Rondinelli, a great team. And I apologize because I'm surely forgetting men. Sorry, but I really wanted to say this. Anyway, let's go back to your question.
Thank you so much. Very kind of you.
Thank you. Yes.
It's interdisciplinary. We can't do this without each other.
Mm-hmm.
The doctors are
Yes.
important, the nurses are important, the pharmacists, the lab, so many people. We were all in this together, and that's a really great point. You've been doing some interesting work lately too. It's same here in the United States as it is in Italy. Patients are waiting several hours to be seen in the emergency department. I believe it's the same in your region of Italy.
Yes, I don't know the regional data, the Lombardy data, that is the region I live, but a recent Italian national report for 2022 tells us that the time interval between arrival in emergency department and discharge for green codes, which identify patients with hemodynamic stability, is almost 4 hours, a lot of time.
It's even longer here sometimes. 4 hours seems
Certainly.
like in and
That's
out.
nothing. Yeah. You could be there all
I mean,
day.
honestly, why is there a backlog?
Probably because too many people, one of the reasons is that too many people go to the emergency department for conditions that should be treated by the general practitioner. Just to give you some numbers, I looked at national reports from some European countries and USA, and they show that about 30% of the population goes to the emergency department each year. In Italy, that's around 18 million people and almost 140 million in the United
Wow.
States. It's also because going to the emergency department is often the quickest way in Italy to get instrumental examination like CT scans or magnetic resonance. We usually have very long waiting lists. Lastly, in my opinion, because the emergency department staff has often been understaffed for years now, and this is a particular problem in Italy. Great problem in Italy.
Your paper discussed creating an anemia clinic out of the emergency department and providing IV iron. Can you tell us a little bit more about that and why this is such a big need?
because the percentage of anemic patients is high, over 40%, more or less, because half of these have iron deficiency anemia. And because in these cases, intravenous iron is unfortunately rarely used. Instead, transfusion is preferred in asymptomatic hemodynamically stable patients. Lastly, because many transfusions are performed in the emergency department. For example, in Italy, we have a survey showing that more than 1/3 of the units transfused in a hospital are given in the emergency department. A huge number.
Yeah.
Can link back to your question about transfusion appropriateness. Early in this month, I started a survey to see how much my colleagues in the 3 hospitals of my consortium know about PBM. To the question, do you use protocol or guidelines for transfusion? Only 40% answer yes, always. The rest answer sometimes, never, or I don't know if they exist. Quite worrying, isn't it? And this is because how to transfuse it taught neither at university nor specialty school. But except the ophthalmologist, I don't know, the dermatologist, everyone has to prescribe a transfusion sooner or later. In fact, a report published in the United States on data from 2010 showed that blood transfusion was the most common procedure performed during hospitalization. And I often use the example of medieval minstrel. He would tell a story he had heard from someone else, who in turn had heard it from someone before him, and he would then tell it to someone after him. In the same way, transfusion practice is often based on habits, tradition, rather than true evidence.
It's common for physicians to order blood transfusions without really doing any type of diagnosis. What kind of laboratory assessments are needed to actually fully diagnose anemia? Like frequently we see they just treat it with a transfusion, but really we need to get to the reason and the heart of the matter.
First of all, unfortunately, it still happens quite often. Sometimes this happens because the time pressure, lack of specific training in patient lab management, or limited access to rapid laboratory tests. This approach can lead to inappropriate transfusions, since treating the cause for is often safer, cheaper, and more effective in the long term, as we know. But before deciding to transfuse, we really need to look at the patient as a whole. Their age, medical history, medications, comorbidities, and their short and medium-term risk of bleeding. This may sound a bit unusual, but paradoxical, this is my opinion, the decision whether to transfuse or not should probably be made before we even look at the hemoglobin value. The laboratory assessment, sometimes you can suspect iron deficiency just for a simple blood count when you see microcytosis or thrombocytosis, especially if the patient has a history of chronic bleeding. But the confirmation comes from transferrin saturation, ferritin concentration, or in case of macrocytosis from folate and B12 levels. I have to say that in my experience, it's quite common to see combined of iron and hematinic, especially in elderly patients. Reticulocytes and noisy markers such as LDH can be used for ruling out other types of anemia. That therapy without iron or hematinics is not always an absolute alternative transfusion, but sometimes rather a means of reducing the number of units transfused. Before saying yes to blood transfusion, patients should ask if it's really needed and if there are any alternatives. They should understand the risk and benefit too. It's not by chance that patient empowerment is emphasized in the definition of PBM. We have a responsibility to strengthen patient empowerment in transfusion therapy as it leads to more conscious and informed choice for both patients and physicians.
So I'm really interested though in this anemia management in the emergency department because currently right now I'm trying to help my hospital build an anemia clinic. It's very complicated, and surgeons have to find the patients, and there's a lot of layers that the patient has to go through. But in the emergency department, they come to you, they're anemic. How do you manage this? Could you tell us a little bit about the workflow and how this works? Because it seems so much more simple.
Actually, to build an anemia clinic, fast-track anemia clinic in emergency department is quite simple. Maybe simple for me that I already implemented this option. In the editorial published this year in Blood Transfusion, together with Carlos Jericho and Manuel Quintana Diaz, we suggest a 10-step pathway to implement a fast-track process in the emergency department. To start the implementation project, we need three key concepts, in my opinion: knowledge, engagement, and sharing. The initial step involves educating healthcare professionals working in the emergency department about the principles of PBM and organizing dedicated sessions of emphasize the importance of implementing this approach. We need then the laboratory's collaboration so that iron nematodes test can be ordered urgently, and the pharmacy support to make sure the drugs are available in the emergency department. But beyond that, a multidisciplinary approach is essential. Clinicians, nurses, pharmacists, and laboratory staff, as I just mentioned, all have to work together if we really want to implement PBM effectively. And the last step of this pathway, in some respects, perhaps one of the most important, is connecting the patient with the anemia clinic. Usually about 10 days later for post-discharge follow-up. This follow-up focus primarily on assessing the effectiveness of the treatment started in the emergency department and deciding whether it should be continued.
Can you define a word for me? Because I've heard this word twice now, and I'm concerned that maybe our listeners are not familiar with the word hematinics. Hematinics, yes.
Okay, hematinics, folate and B12. There are both important for hematopoiesis.
So you talked a little bit about the hemoglobin of 7. Where does that even come from? I mean, is that an arbitrary number? Or, I mean, you had mentioned some patients do well with lower hemoglobin. So why do we use 7?
The problem is sometimes the mistake is made of applying AABB guidelines to patients with chronic deficiency anemia. This is profoundly wrong because those guidelines concern for post-operative patients, intensive care patients, and other types of patients who are completely different from the ones I'm talking about. To be honest, I can say what the absolute hemoglobin threshold for transfusion should be in these patients. As you mentioned in the Legnano case series, there are patients with the hemoglobin below 4 whom we did not consider necessary to transfuse, and none of them had a complication. If I may add, a previous study, we showed that the patients who were only transfused were more likely to return to the emergency department for another transfusion compared to those who had been treated with intravenous iron alone. In the latter case, we had restored blood health.
You're actually addressing the issue instead
Yeah.
of just putting a Band-Aid on it. When you give a transfusion, I don't think a lot of people are aware that you actually are blunting the body's ability to create red blood cells. So when you're giving the iron, you're actually teeing up the person to make their own red blood cells, which is much healthier for them.
It's not really that uncommon to see someone walk into the ER because they're a little tired or they fell or they're a little dizzy, and then their hemoglobin's 3. I've seen it several times. Hemoglobin's 4. The old school way is just, order up the packed red blood cells. But really, that's not the best case. And we need to change that culture because, again, it's just culture.
Yeah.
What about plasma? I know you've written a lot on plasma transfusion. What was it? The efficacy of a strict surveillance policy towards inappropriateness of plasma transfusion. I have the paper sitting here. What is plasma and how does that play a role in our body?
Plasma is the liquid component of blood,
Mm-hmm.
representing about 55 of its total volume. It's a so-called fluid composed of roughly 90% water, which serves as the medium in which cells and extraordinary variety of cells are suspended. Those includes electrolytes, nutrients, hormones, waste product, and most importantly, plasma proteins, such as albumin, immunoglobulins, and the coagulation factors responsible for hemostasis. Plasma can be obtained either from the separation of whole blood or by apheresis and is stored frozen. From a transfusion perspective, plasma can follow too many pathways after collection. It can be used directly for transfusion after thawing, and patient will require replacement of multiple clotting factors. The second way is plasma can be sent frozen to pharmaceutical companies for fractionations, a process through which the proteins are separated and purified to produce plasma derived medicinal products. This includes coagulation factor concentrates, for example, for patient with hemophilia, albumin for volume extension or liver disease, and immunoglobulin used in immunodeficiencies and autoimmune disorders. So while plasma is mostly water, its biological and therapeutical value comes from the complex mixture of proteins and substances it carries, making it both an essential transfusion component and a strategic raw material for life-saving therapies.
I think you said in the paper that there's 50% of plasma transfusions are inappropriate. It's really that overused?
That's absolutely right. And unfortunately, this is something that has been consistently highlighted in the scientific literature. Several studies have shown that around 50% of plasma transfusions are inappropriate, actually, meaning they don't meet the criteria recommended by international guidelines. In fact, depending on the clinical context and the type of audit performance, are reports describing inappropriateness rates as high as 80%, which is really striking when you consider the potential risks and costs involved. In many cases, plasma is administered when there is no clear evidence of benefit. This is a real life. For example, in patients with only mildly prolonged coagulation of test, or when it's used as a kind of general supportive measure rather than for the replacement of clotting factors in bleeding patients. I believe there are two main issues. First, there is still some misunderstanding about the real efficacy of plasma. Many clinicians tend to overestimate its ability to correct modest coagulation abnormalities, so to prevent bleeding in non-bleeding patients. However, we know that plasma has very limited corrective effect unless multiple coagulation factors are medically reduced, and the necessary transfusion can expose patients to avoidable risks. In my experience, plasma is often regarded as a kind of panacea, believed to improve nutritional deficiencies and promote wound healing and so on. When institutions introduce strict surveillance and feedback systems, as we did in our own experience, you said it, just cited, the rate of inappropriate plasma transfusions can be significantly reduced and importantly without any negative impact on patient outcomes. So it's not a matter of negligence, it's more about habit, exactly with the red blood cells or habits, limited awareness and sufficient feedback mechanism. Addressing this through education, another time education, monitoring and structural transfusion governance can make a real difference.
So if 50% of those transfusions are inappropriate, meaning probably not beneficial, is it also causing harm? I mean,
As every inappropriate therapy lead to a harm. Over-transfusion plasma is not harmless. It exposes
Right.
patients to several well-documented risks. Two main clinical significant complications are TACO, transfusion-associated circulatory overload, and TRALI, that is transfusion-related acute light injury. TACO occurs when the volume or rate of transfusion exceeds the patient's cardiovascular capacity, leading to pulmonary edema, hypoxia, and sometimes cardiac failure. It's a particularly common in elderly patients, those with cardiac or renal impairment, with cirrhosis, with portal hypertension. Importantly, TACO is often under-recognized and underreported, meaning that the true frequency is probably higher than the surveillance data suggests. Prospective studies specifically designed to detect TACO after transfusion of red blood cell, plasma, or blood have found incidences as high as 1 in 100 transfusion episodes, especially in high-risk population. According to the hemovigilance data from the UK, from the USA, and Europe, TACO is now the leading cause of death, accounting for roughly 30-40% of fatal reactions. And yes, a huge number. The first cause of death from transfusion. TRALI, on the other hand, is an immune-mediated reaction that causes acute non-cardiogenic pulmonary edema, typically within 6 hours of transfusion. Is much rare today, about 5,000, 10,000 plasma transfusions, thanks to preventive measures such as using plasma for male donors or females who have ever been pregnant. In addition, excessive plasma use may cause other complications such as allergic reaction, febrile reaction, very less commonly transmission of infection. In short, overtransfusion increases risk without adding benefit in 50% of cases. As early as 1992, British Committee for Standards of Hematology had already stated that plasma should be used as therapy only for bleeding patients. Yet in nearly a quarter of a century has passed, those guidelines remain largely implemented.
Why, if there is a lot of risk and people know about this, why does this overtransfusion occur?
There are only few indications for plasma.
Mhm.
Okay. And it happens that the clinician don't follow these indications. Is a huge problem in transfusion medicine for all hemocomponents and also for hemoderivatives. For plasma, the indication are clinical significant bleeding in
Mhm.
patients with an altered coagulation profile, more than 1.5 of PT and APTT, urgent reversal of vitamin K antagonists only if the proton B complex concentrate is not available. plasma exchange in TTP, in thrombotic thrombocytopenic purpura, bleeding or higher risk invasive procedures, and massive transfusion protocols.
The good practice to ensure ordering practices are based on evidence. How does that work? How do you support that and champion that?
Regarding the project we built in Legnano, starting in 2010, in the first phase we recorded the historical consumption data, and then we moved on to the educational phase, which lasted about 4 years. During that time, we provided continuous training to clinicians on the appropriate indications, not only for plasma, but also for other components. Then, from 2014 onwards, we adopted what we call a zero tolerance approach. We agree on the indication together, and then from that point on, they have to be followed. In cardiac surgery, the introduction of viscoelastic testing was particularly helpful, resulting in approximately 80% reduction in plasma transfusion, as we showed in the study which we published last year. Most important thing, it was also almost like a little miracle, was that starting from 2015, we saw a sharp drop in inappropriate requests. That means we actually managed to change the culture. And that's the real goal of any educational project. In 2023, when I complete my work at Legnano Hospital, plasma consumption had decreased about 90% compared with 2010. 90%. Because the culture is changed. The plasma that was not used for clinical purposes was sent to the fractionation industry, which returned about 500,000 euros worth of plasma-derived products. The second way for using plasma. But there are another problem. Underdosing plasma is also a form of inappropriate use. When plasma is indicated, it should be transfused at the correct dose to achieve any hemostatic benefit. Otherwise, the patient is only exposed to the potential adverse effects without gaining any real advantage. As I mentioned earlier, it's been almost a year since I started working in this consortium. And one of the first things I did was organize a series of meetings focused on plasma transfusion, my passion, plasma transfusion. These have already produced tangible results. In fact, in the first 8 months of this year, plasma consumption dropped by 44% compared with the same period of last year. And I'm proud of this result.
What's the most important thing you want to make sure that our audience takes away from this discussion today?
The main message I'd like to leave is that patient blood management is about people, not just blood.
I love it.
It's about changing habits, sharing knowledge, and working together. You don't need miracles, just education, data, and teamwork. When you build a culture of understanding, everything else follows. And my advice to patients is to learn about the available alternatives to transfusion and to ask whether these options are being considered. This protects both the patient and the physician. Thanks again for inviting me. I really hope this conversation helps to spread the culture of PBM.
Your